So now it's turn to Professor Velchev to continue with this path of the molecular era. Where are we now? So Vasil, you have the floor.
Okay, what's so fascinating about hypertrophic cardiomyopathy that it was kind of a model for cardiac hemodynamic since the days of the young Braunwald joined the National Center in Bethesda. Okay, so what do we know? We know that patients are born normal, and then because of some genetic reasons, some of them develop so-called classical phenotype. That means they have asymmetric hypertrophy, which is sometimes complicated by outflow obstruction, sometimes not. And a small part of this patient will develop finally overt LV dysfunction because they will kind of burn up. But we don't know which patient is going to follow this phenotype yet. It depends on the certain mutation and maybe something else what we miss, because not all mutations are the same, and we cannot predict how the disease will develop just based on the mutation of the patient. We have some nice drugs working already for some 40 years. Dizoparamide is not very popular in Bulgaria, but beta blockers and calcium antagonists are doing their job for the certain amount of patient. But of course, up until now, we have some failures for the highly symptomatic patients, and some of them were evaluated for the septal reduction therapy. Traditional drugs are good for symptomatic measurement. They don't change the prognosis of the patient. And invasive treatment, like septal myectomy, alcohol ablation, is something which was very much developed for the last, I would say, 40 years. And we have a big experience and know that successful myectomy is really changing the lifestyle and probably the prognosis of the patient. The problem with the surgery is it's not very easy to establish an expert center, because you have to concentrate the few patients that are severely enough to go for surgery. And especially in Bulgaria, as far as I know, there is no one center who is concentrating, and most of the myectomies are like a single-digit number for a center per year. As for the alcohol septal ablation, much less invasive. And usually what you do, you try to reproduce the surgical result by putting some alcohol inside the septum, hoping that it will remodel the outflow tract, and finally will have abolishment of the gradient. The problem with the alcohol ablation is that some patients don't have good septal, and something like 20% of the procedure are not successful in the long term. But for the 80% of the patient, you're okay. Of course, it's difficult to deal with the very severely hypertrophied septum, and it's not always possible to achieve the perfect results. Nowadays, the Chinese guy developed some very clever procedure, which is not popular in Europe. I personally never witnessed one. But you go percutaneously with a needle and you deliver some energy inside the septum, and they claim to achieve the same results. They kind of fry the basal septum, and the positive remodeling which follows delivers some relief of the gradient. As I said, it's highly invasive. It's not very popular in Europe. So nowadays, if you go for a reduction therapy, first of all, your patients have to be highly symptomatic. It should fail the drug treatment, and you have multiple considerations when you decide what to do. But first of all, it depends on whether you have an expert center doing alcohol ablation besides you, or you have an expert center doing myectomy. Of course, then you have to consider the site of obstruction, the surgical pathology beside the outflow tract obstruction, and finally you may offer a relief of the symptoms for most of your patients. And nowadays we have a new commerce on board. It's a new class of drugs, myosin inhibitors. As Ivo said, there's the class of drugs which are interacting with the myosin-actin interaction, and they kind of block this excessive force for contraction. And if you have myosin inhibitors on board, usually you have less myosin available for interaction, and it kind of have a negative lusiotropic effect. A therapeutic indication, according to the studies that we have so far, is a symptomatic hypertrophic cardiomyopathy. For the time being, we don't treat asymptomatic patient, so we don't treat class 1 patient. And we know that if you are class 2 and 3, and you are treated by myosin inhibitors, you have a very, very good chance to be asymptomatic after a few months. The problem is that if you withdraw the treatment, you slowly go back to the previous state, so the effect is not long-lasting. So for the time being, you have to tell to the patient, okay, you have a very effective treatment, and we can give it to you, but it will be effective as long as you take the pill. Once you don't take the pill, the treatment is not so effective. And for the future, I hope that we will have some experience in Bulgaria also. Following the guidelines, we are obliged to offer the medical treatment before we go for septal reduction therapy. And we know from the studies that we offer the myosin inhibitors, we drastically reduce the amount of the patient which are needing septal reduction therapy. And probably the problem in the future will be to maintain the experience with both surgery and alcoholic ablation, because a few patients will be reaching this invasive treatment. And of course, we have to tell the patient, what do you want? To have the pill for the rest of your life, or we may try some invasive procedure, but it will have some consequences for you, and we cannot guarantee that you will be free of any complication. The hope for the future is the gene therapies, because for the 20 to 40% of the patient, we know that we have certain genetic mutations. And of course, if the genetics are so clever to think out some way to abolish the effect of the mutated myosin gene, it will be cure for the patient, but for the time being, it's not there. Maybe it's in the future. So in summary, we have already good treatment for the hypertrophic obstructive cardiomyopathy. Nowadays, we have even better options with myosin inhibitors, and I can foresee for the future that most of these patients will be treated by medication, and only a few which are not good candidates or want to live without having a pill will go for some invasive treatment. Okay, thank you, and I will be giving the floor to the Professor Postagian.